welcome to this evening's broadcast for tomorrow's Podiatry. My name is Claire Freeman. I'm a consultant podiatric surgeon and I work in Wiltshire. I have an employed job that I do 2 days a week for Independent Health Group, where I do NHS contract work, and I also have a private practice in Salisbury where I work on Fridays. So this evening I'm joined by my friend and colleague Nicola Burt. Nicola, perhaps you'd like to introduce yourself?
Yeah, so my name is Nicola Burt. I'm a staff podiatrist, or slash, shall we say, advanced podiatrist in podiatric surgery in Nottinghamshire Trust. So I work there 5 days a week at present. So I do anything sort of in and around perioperative management and assist along some lovely consultants and registrars.
Good. So tonight we are doing a presentation where we want lots of interaction from our audience. We've got a series of questions and we've got a series of case studies that we're going to present and discuss with you. So the subject today is X-rays. It's all black and white. So before we go on to talk about our case studies or ask you to interact with us much more than this, I want to start by looking at some questions. I've got 6 questions for you this evening, and there's a very simple way for you to contribute to this. We're going to put up the question on the screen. I'm going to read it out to you, and then you get the opportunity to vote yes or no. It's as simple as that. Black and white, yes or no. And then we're going to look at the answers to these questions, and we're going to bring those into the case studies that we discuss later. So Mike is busy working away in the background here. Do you think you could put up question number 1 for us, please?
Okay, I'm just working on it right now, so I should put it up ASAP for you.
Okay, so he's putting it up. I'm going to read it out to you. So remember, the answer is yes or no. Okay, simple as that, black and white. So the question is, would you, I'll get my teeth back in, would you request an X-ray for hallux valgus? So it's a simple question. Would you request an X-ray for hallux valgus? Mike's going to put up the question for you and the option for you to answer, yes or no, black or white.
And that's nice and easy. So Claire, that's now up and will be live. So if you're watching this live, you can pop the results up there. I shall pop the results in for you later.
Okay, that's great. So what we're going to do to start off this evening, we're going to talk about X-rays and IRMA. And then in the second half of the presentation, we're going to talk about the case studies. And it will all become very obvious and clear to you why we've asked these questions when we come back to it later. So could we have the first slide, please, Mike? Aha, that is the first slide. It's all black and white, X-rays, and that's myself, Claire, and Nicola. So Nicola's put up some learning outcomes for you here, and I don't want you to feel like this is a lecture, but when you go back and review this later at some date, or people who may look at it who haven't listened to us live, then it just gives an idea of the things that we're kind of prompting you towards this evening. So don't worry too much about learning outcomes, because there is no test at the end of it. There's only 6 questions that you have to answer yes or no to. Okay, so next slide, please. Okay, so first of all, I just want to talk to you a little bit about IRMA. So what does it mean? And why does it exist, and what do we use X-rays for? So just kind of backtracking a little bit on that. So I'm sure that you've all heard of Marie Curie, you know, because we're all aware of the charity which is in her name. But of course, Marie Curie was an absolutely amazing woman. She was a French-Polish scientist, and she won 2 Nobel Prizes. And in particular, she won a Nobel Prize for the work she did in discovering radiation, in particular radium and, I can't think of the other one polonium, that's right, and polonium. And it's really sad because she didn't realize the power of what she was doing in terms of how it was going to be used in nuclear medicine. And she also didn't realize the dangers of what she was discovering as well, because she died early. She was only 67 when she died. And when she died, she was nearly blind from cataracts that she had. And it was probably anemia or leukemia, which was her cause of death, which was almost inevitably due to the exposure that she had undergone herself. So we've come a long way since she discovered medical uses of radiation. And obviously now we're very aware of the dangers of radiation. So this is what IRMA is all about. It's the ionizing radiation medical exposure regulations. And this is all about keeping everybody safe, from the patients to the practitioners to the general public, to make sure that we're using this fantastic facility in a really safe way. So can we move to slide 2? Oh, I've told you what it means.
So probably the next slide, I think.
We are.
Regulations. Oh, that's my part. Okay. So I did a little bit of digging around some regulations, really, because the regulations are always complex and they just change over time. So effectively, it's training to permit health professionals to undertake imaging with ionizing radiation. So it was amended so I think the regulations, or IRMA, was in place around 2017. There was one that was around 2017 that was amended in 2018. And now you can get the training online as e-IRMA, I believe. So essentially it provides like a safeguarding framework for health professionals to undertake treatment, imaging, and all these kind of things to do with exposure, also for research purposes. And I did find a little caption, which all sounds a little bit formal, but I'll read it anyway. It's: regulations enable a legal guideline of interpretation and a point of reference by enforcement authorities when reaching decisions around enforcement. So that sounds all a little bit formal, I think, but basically it's a structured legal framework document, which you can actually find online, and I can also post a link, if anyone wants that, to protect patients, employees, and employers.
Okay, so could we have question number 2, please, Mike? So remember, it's a simple yes or no. It's a black or white answer. So question number 2 is, would you request x-rays for heel pain? So would you request x-rays for heel pain? Yes or no? How are we doing on that one, Mike? He's gone very quiet.
Sorry, we have a very slight technical bit, so I'm just updating that. The questions have reverted back to last time, so I am just updating that. So would we request x-rays for heel pain is about to go up. I'm afraid the first question was, have you met a podiatric surgeon? So I'm afraid we will have a slight mistake on that one, but we will come back to it.
Well, I tell you what, shall we do both of those questions again? So heel pain's coming up.
Okay, shall we go back to the first one then? So do you want to repeat that for everybody?
So the very first question is, would you request x-rays for hallux valgus?
Perfect. That will be coming up in just a second.
So will that now be question 1? When we
Yes.
come to look at the results?
Yes, it will be.
It will be. Okay. And then the second question was, would you request x-rays for heel pain?
And we'll have that coming up in just a second for you. So we'll do that for a couple of seconds, let everybody have a chance to answer, and then we'll get the second one up in a second.
Okay. So if we could go on to the next slide as well, please. Restrictions. So I think before we start talking about restrictions, perhaps it would be a really good idea to talk about what x-rays can be used for. And there's a massive amount of reasons why you might request x-rays and how they can help you. So it can be used for diagnosis, to help you with your management plan or your treatment plan. They can be used in occupational health to see if people are carrying diseases such as chest x-rays. It can be used for surveillance or health screening, or it can be used in research. or in medical legal issues. So there are lots of reasons why X-rays might be used. And then in terms of the restrictions, obviously there are some times when you wouldn't want to do X-rays. In other words, the most obvious one is with pregnant ladies, because why would you expose a fetus unnecessarily? Or well, it might be necessary. Obviously, sometimes if it's a trauma case or an emergency, then there's a really good reason for doing X-rays, but it would often be avoided. I can speak from personal experience there. I can remember when I was, I think I was 7 months pregnant, and I tripped up in the dentist, and as you do, and I twisted my ankle so badly that I was convinced that I had done an avulsion fracture. I mean, it was, I can't even begin to tell you how painful it was. And I couldn't wait there, which is really pretty difficult when you're 7 months pregnant. And they put me in an ambulance and took me to the hospital, and they wouldn't x-ray me. Even though I was convinced it was fractured, they wouldn't x-ray me because I was pregnant. So as far as they were concerned, this would then affect the treatment. So that's just a little by story about when you wouldn't x-ray somebody, even when you think there's a fracture. So the other reasons you might not x-ray somebody, or you wouldn't x-ray somebody, is if they refused an x-ray or if they didn't give consent. And if you are going to do an x-ray, then you need to think about exactly what you're x-raying, what images you want, which particular views you want, and how you would approach that. So I think there's a very useful adage there about the rule of twos. So usually if you're looking for some kind of pathology, you take two views. You take a view which shows two joints either side of where you think the pathology is, whether it's a fracture or whether it's osteoarthritis or whatever. Sometimes you take two sides, so left and right, so you could compare what the sides look like. And then you look for more than one problem in there. So to really look into an X-ray so that you don't miss things, which may be incidental, but they also might be adding to the pathology. There are times when you consider taking two images at a time lag. So it might be take one 1 week and take one in 4 weeks time or something like that. And this is something which I do sometimes to chart a healing process after somebody's had surgery. So that's kind of like a broad spectrum about restrictions. It's more actually to do with when you would do an X-ray and why you would do an X-ray. So can we move on to question 3, please, in our quiz, Mike?
Indeed, we can.
So question 3 is, would you request an X-ray for neuroma? Would you request an X-ray for neuroma? So it's a yes or no answer. It's black or it's white. How are you doing there, Mike?
And that's now active.
And when you've done that, if you could put up the next slide as well.
Access. Okay, so access then is agreed by employers, I guess, once the employee has been verified, qualified to undertake within the facility. So this is usually done via PACS. And I mean, I say that in terms of my own experience as well. And I don't recall, you might know other than.
What does PACS mean, Nicola?
PACS, good question.
Because most of our listeners probably don't know what PACS is.
Okay, so I understand that PACS is basically it's like a clinical tool that you can get the actual the physical image up once the radiograph has been taken, and it's really, you can do different things on it. You can measure different angles, etc. So forth. So you can use different tools to create a greater clinical picture per your treatment plan.
So it's a software program, isn't it? Mm-hmm. Which means that you can access the images digitally and then you can manipulate them digitally as well. So as you're saying, you can measure angles and distances, you can flip them from one side to the other, you can rotate them around, because there's a very respected way of presenting a foot image, and I'll come to that when we start talking about case studies. But sometimes radiographers will take a foot image at a slightly funny angle, and I can only read it, I can only look at it if it's the right way up, so I need to flip it around and things like that. So you can do that with a PACS system because it's a software program, which means you can manipulate the image. Sorry, I butted in then, didn't I?
No, not at all. No, by all means. I've just seen Mike come up on screen as our little IT fairy. So is that, are you all right, Mike?
You're absolutely fine. I just pressed the wrong button. Thank you.
Oh. That's fine. Okay. So yeah, our access sensor, it's usually done via the system, this software system PACS. So your radiology department, wherever that you work, providing that you're, I guess, working under the umbrella of radiology as well as your own department and others, they need to be on board with your department, having had an agreement already in place for appropriate referrals and requests. And then I guess IT gets involved to just cross-verify everything, dot the I's, cross the T's, etc., so forth, so that you can then access these software systems.
Okay, so can we go on to question 4, please?
Yes, you can.
So, question 4 for you to answer either yes or no is, would you request X-rays for Achilles pathology?
That will be go live in just a second.
Would you request X-rays for Achilles pathology? We are getting some answers to these, aren't we, Mike?
We are indeed. We are indeed.
Good.
We had some great ones to start on. So I know as we go through these, it's a little bit more tricky, but please do, even if you're not getting them or requesting them, it's really useful to have. So do just pop up your answers on there. It's really appreciated. And that's it now live for you.
Okay. And then if we can go on to the next slide as well, please. So this is about reporting. So there are several issues around reporting. And this is something to do with who's responsible for what stage of the process, and also who's responsible overall. So often we talk about reporting is when the radiologists will look at an image and then write their opinion of what they're seeing on the image. And that's just the sort of the standard term for reporting on it. And in all big units, those images will be reported on by the radiologists, who are people who are qualified and very experienced at looking at these images, who can make those diagnostic judgments on them. But I think if you look at it in a sort of wider frame, it's interesting to see who plays what role in that reporting system. So, for instance, the referrer, that might be myself. So I'm the person who refers to the department saying, please, can I have an X-ray? This is the kind of X-ray that I want. And these are the images that I want. And this is the justification for it. And you will not get an X-ray taken unless you give that information on your request, because it's not the job of the person who takes the image, in other words, the practitioner, to make a decision about what you need clinically. So, for instance, if I wanted to take to have some X-rays taken, I would nearly always ask for weight bearing. So you have to say which foot, left foot, weight bearing or standing, which is the same thing, because very often, if you don't ask for that, the images will be taken non-weight bearing, and that doesn't give me enough kind of clinical information for what I want to collect. So it will be left foot, standing, and then the views that I want. And it's very important to, each time you ask for a view, to be able to justify why you want that view. So I talked a little bit about the rule of twos, like you take 2 images, 2 different views and 2 joints, etc., etc. So for instance, if it was a hallux valgus that I was looking at, and we'll come to that a bit later, then I'd want a standing image, because we all know that the foot is slightly different when you're standing on it and weight bearing to when you're non-weight bearing. So I'd want left foot, standing. and I nearly always want an anterior posterior view. Some people call it dorsoplantar, but anterior posterior is the sort of more accepted term. And then I'd also want a lateral view as well, which gives you sort of sagittal plane deformity. And those are probably the only two that I want. Now, it's really interesting because in most X-ray departments, they would usually take a non-weight bearing AP and an oblique, which gives you a sort of, it looks at the joint slightly better, but it really doesn't give you that sort of functional information or the sort of the anatomical positions in relation to each other, which are really important when you're making surgical decisions. So that's a little bit about how myself as the practitioner is responsible for making that referral. And then the practitioner I'm the referrers, and then the practitioner is the person who actually takes the images. So these are the radiographers who have done their degrees in nuclear medicine, and they're aware of all of these risks and dangers of radiation. And it's important for them to protect themselves as much as they're protecting their patient and the general public as well. So they will wear lead aprons, and there's the inverse square rule, which is about, you know, the distance you are away from the source of the radiation. The radiation dose that you get drops by a significant amount. So, you know, just a little bit further away means the radiation dose drops, and then they have lead-lined rooms that they can go into so they're not exposed to the radiation, and they will carry a little device which counts their radiation exposure as well. And this is part of the occupational health for those people who are working with and taking x-rays on a daily basis, or, you know, hourly minute basis. And then there's the radiologists who will do the reporting of it. And we're talking specifically about x-rays here. There's lots of different diagnostic imaging, but this is about x-rays. So any accidental exposure or unintended exposure does have to be reported to the CQC or the Health and Safety Executive. And whoever runs the department where the x-rays have been taken is responsible to see that all of those people in that chain, which is the referrer and the practitioner and the reporter, are properly qualified and have done updates. They've done their CPD on a I think it's biannual basis, to make sure that they adhere to all of the regulations to keep everybody safe. So that's quite a lot of spiel around reporting, and I brought some other things into that as well. So I hope that's kind of useful to give you a flavour of what's going on there. So can we go on to question 5, please, Mike? Which is, again, it's a simple yes or no answer. It's black or white. So would you request x-rays for a hammer toe?
Fantastic. And that is just going live for you now.
Okay, that's great. And then if we could have up the next slide as well.
So training, I think, Claire, there's a couple of things there that you also mentioned that is the training, but I just thought that I would touch on training in a sense that it can be face to face or it can be online, as much what I said earlier. So usually it's about 1 or 2 days. Sometimes the refreshers can be a lot less than that. It depends on sort of who you go through to obtain your IRMA, really. So essentially the refresher course, I believe the refresher course, you said biannually, because I thought it was 5 years. So yeah, this is the thing, it changes.
More than that. It seems to come around very quickly for me.
Yeah.
So you're right. I think it is 4 or 5 years, but I always seem to be having to go and redo it. And you're right, Nicola, that you can do it on e-learning for health. For the updates, but I think the original IRMA certificate is at least a day course and is quite often built into master's modules. So if you're doing a diagnostic imaging module, it will be part of that diagnostic imaging.
So the IRMA, I think it covers the IRMA itself and IRR 17, and there's a little difference between the both. So you get a certificate once you finish everything anyway. So you and I do think that you need that as well after after you qualify, so that you can use that within your department as proof that you have completed this course. And then you can access everything runs all together, doesn't it? So that you can access your imaging and so on, to be able to refer. So the IRMA, I believe, is, and correct me if I'm wrong, Claire, it's the quality standards and quality assurance. So say, for example, if there's a significant accident or unintended exposure to your patient, that's reported to the CQC, whereas the IRR 17 is like a radiation regulation enforcement. So the HSE get involved then when harm is inflicted then on employees or a member of the public is overexposed to radiation. And that's usually, say, something within a workplace. So the HSE get involved with the workplace significance, whereas the CQC get involved with more accidental or unintended exposures to your patient specifically. So the IRMA itself covers all of that, and then you get a little certificate afterwards to say, yes, I've done it, well done.
Yeah. So there's a whole load of things that they go through on those courses. There's the basic physics, which is quite technical, but it's important that you kind of understand how X-rays are made, and then how they're delivered and how they're absorbed into the tissues. So that's the sort of the biological effects of the X-rays. Then it goes on to talk about the effect of radiation on a fetus. So obviously that's something which needs to be acknowledged. Then there's stuff about protecting staff, protecting patients, patient dosages. You'll see on X-ray reports there's a radiation dosage put onto each X-ray, so you know that what dose that patient's had, because the key thing is about radiation is it's cumulative. So once you've been exposed to it, it's within you, and it's not something that you excrete or get rid of. So there's cumulative effect. Each X-ray, I mean, I don't want to sort of get everybody really, really scared about this, but an X-ray is probably the equivalent radiation to a day's sunshine. I don't mean south of France sunshine, but our sunshine of the day in the UK. So it's a tiny amount, but if you're doing lots and lots and lots of those as well, there is a cumulative effect. So there's a little bit about sort of dose auditing, occupational doses, and then the safety of the little devices that people carry. So the personnel who work in radiation with X-rays have a counter which counts their doses that they've received. So there's a lot which is covered in there. It goes to everything from the physics to how you produce an X-ray, to the effect on the human tissues, to the safety regulations, etc. Which is why it is a whole day of training, and for a lot of people it's quite technical as well. It's one of those ones you have to kind of really have quite a lot of coffee to get through. But
it's worthwhile doing it though, isn't it?
Well, I mean, do you know what? I absolutely could not do my job if I couldn't request X-rays, and I think that there are a lot of podiatrists are very scared and worried about doing that, because they think, oh no, we're not qualified to do that. I wouldn't know what to do with an X-ray or whatever. But I think that as we become more diverse in the treatments that we do, I think it's going to be something which should be second nature to a lot of people, particularly as you become a specialist in whatever field of podiatry that you choose to specialize in. That X-rays are just a standard diagnostic imaging. It's ridiculous to even think about sort of CT scans or MRIs unless you know what to do with an X-ray and how to read it, etc. So that's kind of like your basic starting point for diagnostic imaging. So can we have up our last question, please, Mike? Again, it's a yes or no answer. It's black or white. So would you request X-rays for ulceration present for more than 6 weeks?
And that's
would you request X-rays for ulceration present for more than 6 weeks?
And that is up for you.
So what we're going to do now is we're going to move on to our presentations. So if we can have up, so quiz we've done, you can move on from that. Okay, so this is our case study with x-rays. Let's have the next slide. So we have 6 case studies. I'm going to do 3 of them and Nicola's going to do 3 of them. So the first one is about hallux valgus. So the first quiz question that I asked you was, would you request x-rays for hallux valgus? And 75% of you said yes, and 25% of you said no. So let's go on to the next slide, please. Okay, so this is an x-ray that I had taken of a patient, and it is a weight-bearing x-ray of the right foot. So if you look in the top right-hand corner of this image, you can see it says weight-bearing, and there's an R for right. So x-rays will always be labelled up with which foot it is and what kind of an image it is. So for me, this is a preoperative x-ray, and it is a hallux valgus. And the way that I would look at this x-ray is, firstly, I would always have the foot orientated, so the toes are at the top and the heel is at the bottom, because that's how I've been taught to read it. So it's a bit like reading a book. You start at one side and you work your way across the lines, and this is the method that I've been taught to read an x-ray. And if you have it switched up the other way around, I just get really confused and disorientated, and I miss things. And this is just because I guess it would be like trying to eat with your knife and fork in the wrong hand. So your brain is trained to work in a certain way. So for me, this is a preoperative x-ray, and the things that I am interested in looking at is firstly the alignment. So what I would do is I would start at the toes, and I would... Can you see my pointer? No, you can't, because you're not showing my screen. So I would start at the toes, and I would scan from left to right as I come down the image. And so for me, the alignment is really important in hallux valgus. So what I can see is the alignment of the hallux to the first metatarsal is has deviated. Then I look at the bone structure, and you can look to see whether the bone is very greyed out or washed out. So that would give you an idea as to the quality of the strength of the bone. Then, and you might also look for cysts or anything which might look like the bone has been eaten away by tumour or something like that. And then I'd look at the cartilage. So the cartilage on an x-ray is the space in between the bones. So you can see a little black rim at the top of the metatarsal head, the first metatarsal head there, and you can in the lesser metatarsals as well. So that's cartilage. And this is important to see that there is actually some interface between the two bones. And that's particularly important when you've got an osteoarthritic joint, because you tend to lose that cartilage space. And then I'd look at the soft tissues as well. Well, with the soft tissues, so an x-ray doesn't pick up soft tissues particularly well, but it will pick up the outline. And you can definitely see the outline of the soft tissues as it runs around the metatarsal head on the medial side there. And there's quite a lot of thickness of the soft tissues along the 5th metatarsal shaft. So that's what we call the ABCs of looking at an x-ray. So it's alignment, bone, cartilage, and the soft tissue. And that's a standard way of reading an x-ray. So can we go on to the next slide? So what I'm particularly interested in excuse me, is in charting an x-ray. And by charting, again, I go through the same ABCs. So I look at the alignment, the bone density, the cartilage, the soft tissues, but I'll also then look at anything which is incidental or additional. So on this x-ray, what you can see is I've charted the 1 to 2 intermetatarsal angle. So I do this by bisecting the first metatarsal and bisecting the second metatarsal, and see where those two lines intersect. And that tells me there's 15.9, nearly 16 degrees of intermetatarsal from 1 to 2. Now anything more than 8 is moving outside normal parameters. So that's our first key point in terms of charting this to look for a surgical solution. And then the next point I'm looking at is the hallux valgus angle. And again, I do this by bisecting the proximal phalanx of the hallux and bisecting the first metatarsal, and the angle there is 154. So 180 would be completely straight, but that would be ridiculous because the toe would actually be in an adducted position. So this is 26 degrees hallux valgus. Again, anything more than 8 or 10 degrees is outside a normal parabola. And so this gives me an idea of how much correction I need to do on this hallux valgus deformity. What I can also see from there is the metatarsal head is about 1/3 to maybe 50%, no, 1/3 to half subluxed medially. And then I'm also going to look at the sesamoid position. Now you can see those two sesamoids, which should be underneath the metatarsal head. Now, a lot of people describe this as the the sesamoids have deviated laterally. Well, they haven't. They haven't at all. What's happened is the metatarsal head, the metatarsal has deviated medially. The metatarsal should be sitting on top of the sesamoids. So it's not the sesamoids have moved, it's the metatarsal has moved in relation to the sesamoids. And that again gives me an idea about how dysfunctional that joint is, because obviously the sesamoids are sitting in the flexor tendon. So the pulley of the flexor tendon is actually increasing the pathology, which is there. So can we go on to the next slide? So here we have a post-operative. So again, this is a patient that I've operated on, and I'm looking at the alignment, the bone density, the cartilage, soft tissue, and in particular on this, I'm looking at the fixation and the healing. So I generally take an X-ray 4 weeks post-operatively. And what I'm looking for here is that the osteotomies that I have done are stable. They haven't moved. The fixation is where I've put it. There's no evidence of bone callus there, so they're healing up nicely. And in the second toe, I've done a fusion of the proximal interphalangeal joint with a percutaneous K-wire. And this shows me that those two bones are nicely opposed and it's healing really well. So I've used the same principle of a weight-bearing right foot X-ray. This is an AP view, and I've looked at the difference between the charted X-ray that I did when I was looking at the angles. Now, I haven't put angles on here because it would be very difficult for you to see the fixation if I'd drawn a lot of lines on it as well. But this is to show you that what I'm looking for is slightly different in the post-operative period. Okay, so can we move on to the next slide, please? And Nicola is going to talk to you about heel pain.
Heel pain.
Now, interestingly, for heel pain, 25% of you said you would take an X-ray, and 75% said you wouldn't.
So that's interesting, because I think it also depends on your findings, doesn't it? And this comes down to like really what we're talking about, isn't it? What kind of what are we requesting for? And justifying why we're doing it. So I guess the first step is to find out whereabouts in the heel that this patient is experiencing pain, and just talk a little bit more about that history. So this,
Sorry, that was my phone.
Oh, no, that's okay. I don't know if I pressed something. Yeah, so I think it all depends on what we find, what we're looking at, what we're thinking the diagnosis is, and aiming to decipher the differential as well and to rule it out. Can we go to the next slide, please, Mikey? Or IT fairy. Okay, so pre-operative then, I guess this comes under the bracket of history taking, as we say. So I use term NILDCAT. So that's nature, location, duration, onset, cause, aggravated by, and treatments of. So we want to have a look at the clinical assessment. So what do we see? Just remember to treat the patient and not just the X-ray, much like what you were saying as well, Claire, isn't it? Sometimes you'll get these incidental findings. So I guess it's useful to really know about the anatomy and what you're what you're trying to decide, against your differentials per your diagnosis, if that makes sense. Can I go on to the next one, please, Mikey?
I think what's important to say in these is that we think of heel pain as a soft tissue problem. People jump in and think, well, heel pain, it must be plantar fasciitis.
Yeah.
Exactly. They jump into that feeling. And of course, we know that X-rays don't show soft tissue pathology well. You can see outlines of things, but little more than that. But I think it's really important when you look at heel pain to actually know that there's such a wide range of differential diagnosis. And unless you're really vigilant about what you're looking for on in your presenting complaint, you may miss something. As was the case with this patient, I think, wasn't it?
And this was one of yours, Claire's. So take this patient who presents with plantar lateral foot pain, I suspect. So what we're thinking, really, your clinical finding, I have actually put the answer in there. But does anyone actually know what this os perineum is? Maybe you could drop anything in the comments, or, what have you ever experienced this before? Have you ever seen this before? Could you have, potentially mistaken this for something else? Say if you haven't got access to X-rays as well, you may think that this is something else. So sometimes it's useful to have a look at these X-rays as well. Now that you see this in front of you, you know that os perineum can also present as plantar lateral foot pain, which could present as something else. Could it be a nerve entrapment? Could it be soft tissue swelling? Could there be a fracture there? So you're kind of running against different options, really, aren't you? And now if you have access to X-rays, you can really see inside the foot just to see what the root cause of the problem may be. Has this patient exhausted other conservative options? The patient comes as a whole package as well, so you do have to think, I guess, in layers. Have a look at the skin. Is there anything on the skin? Do they have any corns, any callus, anything like that? Have they been on holiday, for example, and trodden on something? And I've experienced this once before, where a patient went swimming on holiday, came back and thought that they fractured their foot, whereas actually no, it wasn't. It was a little fragment of sea urchin stuck in there. So you're looking at all these different things, really. So I just wonder, Claire, do you want to expand a little bit more on this with your patient?
Actually, sometimes if you have a foreign body, that will show up on an X-ray as well. So I had a patient who had been plagued by plantar heel pain, and she'd been treated conservatively and all the rest of it. And I don't think it's in the NICE guidelines to take X-rays if it's considered to be plantar fasciitis. So I did take an X-ray, and she had lots of shotgun pellets in her foot. And I looked at these, and I couldn't believe what I was seeing, actually. And I kind of said to her, have you ever been shot in the foot? And she said, well, no, but I was part of the military, and yeah, something went off near me, and I don't think shotgun pellets wouldn't have come from the military, but she had been used to grew up in a family who had farms and did shooting and things, and shotgun pellets can spray, and she had all these very round objects in her heel, and I said, wow, that looks like pellets to me. Because they're very, very bright, because they reflect a lot of the X-ray as well. So sometimes you find unusual things as well that you're not expecting, and that one took me by surprise.
I'm going to just jump in as well, because I think that because I've got another slide coming up in a little bit, haven't I, Claire? So I'll just hold fire on the next bit of what I'm going to say. Okay. So I'll jump over to you, but then I'll refer back to this one in a moment, I think.
Okay, so I think we're going to go on to our next slide, please. We're talking about neuroma. So when I asked you if you take an X-ray for neuroma, none of you said yes, and 100% of you said no. Okay, so let's go on to the next slide. So the whole point of this slide is to talk about differential diagnosis again. So when you've got somebody who's got a neuroma, you have to understand that all of those structures in the forefoot are so closely aligned that it can be really, really difficult. If somebody comes in and says they've got a radiating pain in their forefoot, and you think, oh, that must be a neuroma because that gives you radiating pain. Feels like I've got a sock rolled up in my shoe. That's another good description of neuroma. But you have to be really careful not to suffer from confirmation bias. And you've decided it's a neuroma, so you make everything else fit the picture. So in your differential diagnosis for a neuroma, there are lots and lots of other things that it could be. Now, it's interesting because this patient, these x-rays that I'm showing you, they came in and described to me the symptoms of neuroma, radiating burning pain in the forefoot, numbness into the second and third toes. So I'm thinking of my differential diagnosis. Is it because there's a hammer toe and there's pressure to the metatarsophalangeal joint, as there might be with a mallet toe? Is there a plantar plate pathology? Is there a tear or extenuation of the plantar plate? Is it a standard metatarsalgia because there's a functional disability there? Is there a hallux rigidus, which means that they're offloading onto the lateral side of the foot? Is there an abnormal metatarsal parabola? In other words, do they naturally have a very long second metatarsal, which means that it takes more pressure? If you look at the plantar pressures on Gait Analysis. So, what I'm saying there is there's a pathological loading pattern, or could there indeed be a Freiberg's? And actually, I forgot to say when I talked to you about the hallux valgus picture, there was a Freiberg's on the second on that image, and that might give a radiating pain into the second toe as well. Or there may indeed be a fracture. So actually, this image is quite interesting because this person has had silastic implants in both feet. And for some reason, on the right side, they didn't put grommets in it. And this is now collapsed into a hallux rigidus. And the hallux is relatively short compared with the second. And they have an abnormal loading pattern. The second toe is pressing down into the metatarsophalangeal joint. And so the symptoms that they described as neuroma aren't neuroma at all. It's to do with their structure. So don't rule out an x-ray when you've got somebody who gives you the presentation or the clinical presentations of neuroma. Unless you're really, really sure that it's a neuroma, then it might well be something else. Okay.
That's really interesting, Claire. Like just going to say that, because I just didn't, I've seen some of these spaces put in before actually, and I didn't actually realize, had you not put a grommet, that it could get like that. Must have been quite horrifically painful for this patient.
And wow. And significant shortening as well of the first net. Yeah. So changes the loading pattern in the foot. So can we go on to the next image? So Nicola's going to talk to you about Achilles pathology. So when I asked if you would take an x-ray, none of you said yes, and 100% of you said no. Interesting. Go for it.
Okay. So can we go on to the next slide, please? Okay, so what do we see here then? So this was one of yours, wasn't
it? It was, yeah.
So I can only assume from, as we say, what we see.
Tell us what you see, Nicola.
Okay, so I see, apart from the glaringly obvious.
Tell us what the glaringly because it's glaringly obvious to you because you look at x-rays, but to the people who don't look at x-rays, what is glaringly obvious on there?
Okay, so I'm firstly going to say what I see. So this is a right foot, judging by the R, and you can see there it's a weight bearing. So this is a weight bearing plain x-ray of the right foot. So I'm going to work from the finding as presented in clinic. I suppose that this person had pain on palpation of the insertion where the Achilles was, and probably across the superior aspect of the Achilles as well. So you can see now the calcaneus, which is the heel bone, and I can't point, but it should be quite uniform and quite rounded at the back, so it should all form in one, like you're drawing with a pen to paper, just one nice round line. Now what you can see here is two little spurs, in fact. There's one at the posterior aspect of the heel bone, and
so
one
this is the point
underneath.
where the Achilles attaches onto the back of the calcaneus, isn't it?
Exactly that. And there's one underneath as well. So I don't suppose, well, sometimes, as we know, plantar fasciitis, if you take an x-ray of the foot, it's part of an incidental finding, isn't it, that you can get a heel spur in a mix with plantar fasciitis. But in terms of sort of this Achilles pathology, you can just see a little, almost like a little flake, like a flare of bone coming away from the back of the heel there.
And also, if you follow the soft tissue, in other words, the outline of where the soft tissue is, you can see that there's quite a significant bump on the posterior surface there. Can you imagine what that's like in a shoe? And also, there's a little ridge just above it, isn't it? This is what we call a Hagelands. So there's a ridge of bone above that as well. So there's sort of two pathologies going on here. But what was interesting is this patient came in and said, I've got a problem with my Achilles. So again, this is a case of not going along the confirmation bias and making everything else fit the description of what you think it is that you've made your mind up in a couple of seconds. So yes, Achilles, it is a soft tissue pathology, isn't it? But looking deeper than the soft tissue pathology is actually as an insertional problem.
So insertional.
I thought that off for you, didn't I?
No, not at all. That's fine. So insertional calcification then is something that we can call this. Now, interestingly enough, that Hagelands there, or Hagelands, so the little bump just above what I call that little flake of bone there, should we say in layman's terms, in clinic, when you look at the back of the heel, it's interesting that the Hagelands is actually higher. It's more superior than what you think. So, you know, we're talking about the difference between, say, what we call a retrocalcaneal exostosis, which is a little bit of bony bump that comes at the back of the heel bone, versus the true Hagelands, which is just superior, almost like it's a little hill on top of the back of the heel bone. So yeah.
Have you got another image there as well?
I think so. Mikey, can you go on to the next one? I think there's
maybe not. Go for it.
So I guess it's the importance of referring back to what you were saying about charting, Claire. So there are lots of different angles that you can use. Lots of textbooks will tell you lots of different things. This is one that I got from a paper actually, where there was quite there's a number of different angles that were thrown in that you can see here. I'm sorry, I just forget some of it because some of them I hadn't actually heard before, and the paper is in my bag down here, so without grabbing it out and having a look at it, I can refer back to this later and pop it down in the comments, unless you know off the top of your head, Claire. But there's things such as calcaneal pitch. There's something that's of French descent as well. Ultimately, there's another one that I was reading about the two measurements to define the difference between an operative and a non-operative Hagelands deformity as well. And they were looking at things like the bone, what they literally called a bony bump incline, and forget the other one as well. But there was a measurement between the both that if it's underneath a certain, sorry, I need to have a look at that paper again, but if it's underneath a certain measurement, then it would class almost as a non-operative picture, so that you could treat it with quite a lot of success conservatively versus having to operate. And do you find that sometimes with you, Claire, that you'll find that, you know, it's kind of that brink of treating the patient versus treating the x-ray though, isn't it?
You're absolutely right, because it's all very well being very technical with your angles and dangles and your measurements and all the rest of it, but you should never lose sight of what the patient is in front of you is complaining of and what their foot looks like. And there have been times where I've looked at an x-ray and I've looked at a foot and I thought, have I got the right x-ray up here? Because it doesn't actually correlate with what I'm seeing clinically. Often clinically it looks a lot worse than it does on the x-ray, and that might be because there's some soft tissue adaptation around it, or a bursa or whatever. But you know, x-ray only gives you part of the puzzle.
Just jumping in about the soft tissue bit, Claire, I think I need to also touch on that in my next bit as well, because I guess I could touch on it here. Can you go back at all, Mikey? I don't know if you can go back to the previous one. Yeah, sometimes you can see, depending on, and correct me if I'm wrong, Claire, but depending on the severity of the soft tissue deformity itself, you can see some ounce of shadowing in the clinical picture as well, and that kind of gives you another supplement and a backup to your diagnoses as well.
Yeah, I mean, certainly if you've got swelling in soft tissues, it's a slightly whiter appearance than normal soft tissues, and likewise if there's infection there, we're going to talk about that in a minute, but if there's infection present, that will look different in the soft tissues as well. So you can get some indication of what's going on in the soft tissues from an X-ray, and you can get different levels of X-ray. So you can get a softer X-ray, which will give you more information if you're looking particularly in the soft tissue interface between that and bone.
Awesome.
So should we move on?
Mm-hmm.
So we're going to talk about hammer toe. We've got two more case studies to talk to you. I know we're coming up to the hour, but we've got two more case studies to present to you. So in terms of a hammer toe, would you request an X-ray? Well, that was a 50-50. We'll call that a grey answer, shall we? It was black and white. Okay, so let's move on to the next slide. So would you take an X-ray for a hammer toe? So I think what's really important when you talk about X-rays is you need to know what looks normal. Okay, so on the left-hand image here, these toes, the lesser digits, they all look very normal to me. And it's common for the proximal phalanx to be much longer than the intermediate phalanx, which is much bigger than the distal phalanx. And then, of course, on the hallux, you've just got the two phalanxes. So I put this one up to show you what a normal toe, what a normal foot would look like, and how I would expect to see the three bones within the second digit. And you can see a small amount of cartilage, which is the black rim, in between the bones there as well. So if you compare that with the image on the right, so this is an oblique image. So the one on the left is an anterior posterior view. The one on the right is an oblique image. And I had this taken on purpose because I wanted to really look within the joint of this particular foot. And with an oblique image, you get a slightly different angle so you can see what's going in the joint spaces. So if you look at the second toe, the proximal phalanx is much shorter than I would expect it to be. It's actually shorter than the intermediate phalanx. And also there's been some adaptation around that as well. So that looks to me like that person's had an arthroplasty on that toe and there've been some adaptation, but it's still in a deviated position. And then again, if I look at the third toe, the intermediate phalanx is about half of what I would expect it to be. Can you see between the intermediate phalanx and the distal phalanx? There's quite a wide, what could be cartilage there. It probably isn't cartilage, it's probably just soft tissue interspace there. So there is some digital deformity there. There are hammer toes there, but taking an image of them really helps me decide what the pathology is at the moment. So there's a hammer toe of the second and slight deviation of the third, but also tells me what the bone structure is like in there. So that might make me make a different decision about what kind of management that I would do for that patient. Now, I use this image particularly because there has been some surgery done there, so it's very obvious to see that there's a difference. But you may have a patient who has a congenital shortening of one digit, and that would be really important to have a good look at before you considered any surgery on it. So that was interesting that there was a 50-50 on that one, but I would, well, certainly in my field, I would certainly err towards if I was going to consider surgery, just so that I could view the whole foot as well. And I think it also gives you an idea of looking at the metatarsal parabula as well, which is the sort of the relationship between the first and the second and third and the fourth. So if you look back on the on the left-hand image there, slightly longer than the first, and that would be a sort of normal parabola. And again, if it was much longer, that might lead to a hammer toe. So if I was going to think of a surgical solution, I might be having to shorten the second metatarsal as well as manage the deformity at the interphalangeal joints. So it would be pretty important for me to take an image there. And also, you know, at a general podiatry level, if you've got a recalcitrant hammer toe, which is causing problems, then an image might help you make decisions about whether this would be a suitable candidate to put forward for surgery or not. Okay, so can we have a look at the next image, please? Oh, I think we'll just skip over this. This is just to show you what kind of horrible deformities you can get in the digits. Not a very good image, so let's go on to the... Oh, this is a lateral view. This is just to show you that the second toe is much higher than the hallux as well. So this is a nasty hammer toe which has been causing a lot of trouble, and that image just helps to show me the orientation of the second proximal phalanx in relation to the hallux and how much I need to bring it down by. So could we move on to the next image, please? Michael says he loves grey. He's just put in the chat there. Michael, could you move on to the next image, please? Thank you, Kelly.
Awesome.
So in terms of ulceration, when we asked you who would take an image for ulceration which has been present for more than 6 weeks, so 100% of you said yes. Interesting.
Mm. So can we go on to the next slide, please, Mikey? Awesome. So this is a picture that I literally got off the internet when I searched up ulceration for longer than 6 weeks. I think it's worthy to say that obviously any ulcer that is ulceration, lasting longer than 6 weeks, I think everyone starts thinking about things like infection, don't we? So we're kind of thinking the obvious signs here. So NICE guidelines actually say do not refer to something called the Wagner or Wagner classification, but you can refer to the Simbad classification. I did put up 2 pictures of this, so we can go on to those slides in just a moment. But I think it's important when we deal with ulceration. This is just such a juicy one because there's so much to talk about with it, but I'll try and summarize.
Perhaps we'll do another webinar on diabetes.
Yeah,
we'll do that one day, shall we?
Yeah, we should. So I think just to summarize them, really, with ulceration, you want to think, how long has it been there for? How did this happen? Take a little bit more history about the person. And then you're thinking about the foot specifically. Are there any pressure points specific? I mean, there's lots of different areas of the foot that ulcers can occur. So, you know, could it be a plantar ulceration? Is there a reason for that to do with pressure? Could it be on top of the foot? Might that be pressure from shoes? So I guess most ulcers, start along the lines of pressure, don't they? However, some can be a little bit more sinister, I guess, than that. If your patient, I mean, some people have diabetes and some don't. Those that do have diabetes, some of them have neuropathy, something called peripheral neuropathy, and some of them don't. Some of them also have other conditions like ischemia as well. So there could be a multifaceted answer to why this ulcer has lasted for longer than 6 weeks. So when you're looking at an X-ray, what you really want to do is think a little bit deeper than is it just infection alone, especially when it comes to someone that can't feel the foot. You know, did they step on something? I once had a patient that was actually a home visit with a recurring ulcer that was classed as an ulceration longer than 6 weeks, kind of kept on healing over them, popping back open again, etc., so forth, and constantly getting treated with antibiotics as well. When I went to them, I managed to do a little bit of sort of deeper debridement, and out popped this weird looking thing that I'm pretty sure it was bone, but I don't know where it came from. Yeah. And so I put it in a little histopot. We sent it off to the lab, and then it came back as a chicken bone.
bone.
A chicken bone. Where did this chicken bone come from?
You've been cheating. But I think that the bottom line is when you take an X-ray, you're looking for evidence of infection. You're looking to see the extent of infection, and you're also looking to see if there's been collapse of joints, such as you get in degenerative joint disease, which may be contributing to the ulcer because there's some kind of structural variation and a pressure point, as you said. So can we just move on to the next slide then? Oh, yeah, there you are. Perioperative. So, you've covered this already, haven't you?
Yeah.
Yeah,
so
you have.
I'm just going to drop
fourth
in there.
metatarsal head. There's some pressure there, isn't there? And that fourth metatarsal head on the X-ray looks very poor quality bone, doesn't it? It's much grayer than the rest of it.
So I think also it's worth having or just thinking about vessel calcification. So this is going back to our soft tissue situation. Now you can sometimes see on an X-ray if someone has very poor vessel calcification, you'll see almost like little tributaries and little rivers of white. And I think it's worth also thinking about something called avascular necroses as well. So some of these patients may have what we think is osteomyelitis, and we're actually treating them for the wrong condition, whereas they may have avascular necroses.
That's very difficult to differentiate between avascular necrosis and infection on X-ray. Even on MRI, sometimes it's tricky as well. So I think we should bring those complicated diabetic things into another webinar, don't you? We've got another slide. Sorry, I'm rushing you on a little bit, Nicola, because I think that we're kind of running out of time. You've talked about the classifications. Can we have the next slide as well?
And that's it, really, I think.
You talked about as well, didn't you? Okay. So, has anybody come up with any questions? I don't think I haven't seen. Oh, it's a private chat I'm looking in. Mikey. Oh, afraid not. No questions tonight. We've stunned you into silence with all of this black and white, have we? The next slide. Next slide. So thank you all for watching. If anybody wants to check up on either of us, there's our Instagram and our websites, etc., etc. And one more slide. Oh, this is just in case you want to check out the career pathway for podiatric surgery again. I know that last time people were very interested to know about the training program, so I found this this informatic, and I just put that in there, so it will be in the YouTube that you can go back and look at a later date if you want to. And then the next slide. Oh, I think that's it, isn't it?
Yeah.
So just to say that the next tomorrow's podiatry will be on the 20th of December. It's not myself or Nicola, but we have some very interesting presentation, searching for centre. Apparently this is forensic podiatry, which I'm sure will be really interesting. Oh, it's called Two Views. Thank you. Yes, Two Views. It's the extra special, looking for centre. And Nicola and I will be back in the new year. We're hoping to do our next presentation in February, and we'll be talking about lifestyle medicine and how that is relevant to podiatry and podiatric surgery. So that's all for tonight. Thank you very much for all of you for listening in.
Thanks, guys.
And we look forward to seeing you again soon. Okay, good night, everyone.
Bye.